CanCOVID is an open science collective dedicated to rapidly mobilizing and sharing knowledge to help inform Canada's COVID-19 response. To learn more about us or how to join our community, you can visit our website at cancovid.ca.
Well, thank you very much, everyone. Welcome to this CanCOVID workshop on COVID vaccines. Allow me to introduce myself. My name is Louis Flamand. I'm a professor and chair of the Department of Microbiology, Infectious Disease and Immunity at Laval University in Quebec City. And I'm also the theme leader in biomedical research, engineering, and science for CanCOVID. As you know, CanCOVID is an open science collective dedicated to rapidly mobilizing and sharing COVID-19 knowledge to support Canada's frontline decision makers. CanCOVID organizes and hosts a weekly speaker series, as well as monthly workshops and special events to highlight emerging and published research throughout the pandemic. So today we'll be having a second workshop on COVID vaccine. And as you know, vaccines, we've made tremendous progress in the development of a safe and effective vaccine within a year, which was a remarkable achievement. But the fact that it went so fast, many questions remain unanswered, and some of them will be attempted to be resolved or addressed by our speakers. So today we have a series of 4 speakers that will present you some information on various aspects of the vaccine, the COVID vaccines, whether in terms of different populations, in terms of immunosuppression, native communities, resistance or efficiencies against the variants. And so we have a very nice sets of 4 distinguished speakers that will entertain you for about 15-20 minutes. And this will be followed by a period of questions, about a 20-minute period of questions. And we ask you to put your questions within the chat box, and then we'll try to go through them as best as we can. And so let you know that this video is being recorded and will be hosted and posted on our YouTube channel. So as a first, let me see if we have our first speaker in the in-house. If not, we'll go to, okay, I think we were supposed to start with Gaston Dessert, but I think he has some issues connecting. So we'll go to our second speaker.
I'm there.
Oh, you were there? Okay, Gaston, welcome. I didn't see you there, so very good. Okay, well, let me go back. So our first speaker is Dr. Gaston Dessert, MD, Ph.D. Dr. Dessert is an epidemiologist at the National Institute of Public Health of Quebec. He's the medical chief of the scientific group on immunization at the NSPQ. He has conducted epidemiological studies on infectious disease and efficacy of safety of vaccines for over 30 years and has published more than 300 papers on these topics. He is an active member of the Quebec Immunization Committee and a member of the Esprit Corps group, which oversees vaccine safety in Quebec. And in April 2020, he was mandated by the National Director of Public Health of Quebec, Dr. Horacio Arruda, to conduct an epidemiological study on healthcare workers affected by COVID-19. And today, Dr. Dessert will speak to us about COVID-19 vaccine effectiveness against the variants. So Gaston, welcome.
Thank you. I'll just try to share my screen. Do you see my screen?
Yes.
Okay. So thank you, Louis, for the introduction. And so I was asked to briefly talk in 10 minutes about the vaccine effectiveness against variants of the SARS-CoV-2. And so I think that I will just skim about those variants of concerns, the protection given against those variants of concerns, but I'll go back to what are those variants of concerns, what define them, what did we learn from the phase 3 clinical trials, and from the vaccine effectiveness studies. So as you can see here, this is coming from GISED. Since the onset of this pandemic, the diversity of SARS-CoV-2 has increased. And as you can see, from the hundreds of thousands of strains that are now in GISED, B117 is the most prevalent variant that has emerged probably in the summer of last year and is now quite frequent. And in Canada, it is the most frequent. In many countries, it is the most frequent variant. However, we have new variants like the so-called Indian variant here. We had the South African, the Brazilian, so P1 for Brazil. We have, sorry, I cannot see behind my screen, but I will talk about these 4 variants that are most important. So what defines a variant of concern is if it increases the transmissibility of the virus, if it increases its virulence. But what I'll talk about is how these variants may have mutations that decrease the effectiveness of the vaccines. And as you can see here, we have the 4 variants that I'll speak about. So the so-called UK variant, the B117, the South African variant B1351, the Indian, which is B1617, but the most important .2, and the Brazilian, Japan is the P1. And so in clinical trials, just to remember, when you want to assess the effectiveness or the efficacy of a vaccine, you have to keep into account that a vaccine doesn't protect instantaneously, and you need to wait for a few days before you start seeing a divergence between the vaccinated group and the placebo group. And basically, you need to wait for 14 days to get this protection. And this is for the Pfizer product. And we can see that after a first dose with the non-variant coronavirus, we had a protection that was already quite substantial, over 90%. And so in phase 3 clinical trials with the Pfizer product, we had with no variants, we had 14 days after the first dose to the second dose, more than 92% vaccine efficacy, and 7 days after the second dose, nearly 95%. For Moderna, again, with no variants, 14 days or more after a first dose, 92%, 94%, 14 days after the second dose. So basically, you had a good protection after 1 dose and after 2 doses. But you'll see that these results in vaccine effectiveness studies are not exactly replicated, at least for the protection after the first dose. For the other category or family of vaccines, so those that are with a viral vector to induce protection. So we have the AstraZeneca vaccine, which has been shown in the study that was conducted in the UK and in Brazil to induce a protection of about 70%. However, there was also part of this, of the RCT that was done in South Africa. And in this South African context, we can see that for the variant B1351, there was a much lower protection. And we can see here that for mild or to moderate illness, 14 days after the second injection, it was 21.9%. And that was for seronegative individuals. And if we look for after 1 dose, then that was for the non-variant, there was a 75% protection. So quite a drop with this variant. And this is why in South Africa, they decided not to use the AstraZeneca, given their context where this variant was quite frequent. So when you look at the Johnson & Johnson RCT, what they found was that for their overall VE, For moderate to severe COVID-19, it was 65%. For severe, it was 83% for all viruses. But they had a component of their clinical trial in South Africa, and when they sequenced the virus, most of them were the B1351 variant. And in Brazil, they had also a preponderance of the P1 lineage. And when we look at the effectiveness here, it didn't drop much when we compare the overall to each of these two countries where we had these variants. But in vaccine effectiveness studies, many came from the UK, where the B117 had been the most frequent variant, starting last summer, but at the end of 2020, it was already the most prevalent component of coronavirus. And so the first studies were, in fact, reporting effectiveness against that variant. And more recently, they had some of this Indian variant that have been circulating. And I'll talk briefly about studies from Canada. So this is the one of the initial studies showing that the reduction of the risk is so in those who had received a first dose of vaccine, they had a reduction of risk of 70%, so 0.30, and after 2 doses of 0.85. So 1 minus 0.15 is 85% protection. And so that was quite a good protection. That was for the Pfizer vaccine during the period from December 7th to February 5th. But as I said at that time, it was mostly the B117 that was circulating. They published recently in medRxiv an analysis where they compare the effectiveness specifically for B117 and also for the B1617 too, to see how it differs. And as you can see, if you have here the Pfizer product, after the first dose, you have a vaccine effectiveness of 49% for the B117, but it drops slightly for the B167 to 33%. After the second dose for the B117, there was pretty much no impact. It was really highly protected. And for the Indian variant, it was also quite substantial. So not much reduction after the second dose, but more so after first dose. For the AstraZeneca product, same thing after first dose, you see a better protection against the B117, but a reduced protection against the B1617 variant. After the second dose, though, you have a lower protection as compared to what we have with the Pfizer product. But this has been true also in their randomized clinical trial, where it still hovered around 70% after 2 doses. This protection after 2 doses with the AstraZeneca vaccine is not identical with any interval following between the 2 doses. If you had a longer interval in their clinical trial, they showed that they had higher protection. But here it's just the overall protection that they have assessed recently. There was so after those 2, as I said, there was a difference also between the AstraZeneca and the Pfizer product. In Qatar, they just recently published the effectiveness against the B1351 variant. And here you have the protection after a first dose. Again, we're talking about the Pfizer product here. So after a first dose, little protection against this variant, better protection 14 days after the second dose. for the severe disease caused by this variant. No protection. Well, there were quite few cases, but no protection against severe disease after a first dose, but very good protection, well, perfect protection after 2 doses. So this is a study from Danuta Skowronski in Vancouver, British Columbia, where she has done a study with her colleagues looking at the a single dose effectiveness of the mRNA vaccines in British Columbia. And there they had non-VOCs, they had B117, and they had also P1, which has not been assessed in many locations. And you can see that for non-VOC, the effectiveness was 71%. We're talking about a single dose of vaccine, not 2 doses. 67 for B117, so minimal drop, and a slightly greater drop for the P1. So for Quebec, we only had B117 in sufficient number to be able to look at the effectiveness. But here we looked at the effectiveness over a period of time extending up to 17 weeks after a single dose. And you can see that the VE overall, the blue line, is quite stable. You can see the non-VOC in orange and the VOC, which is mainly the B117, slightly lower, but again, with the sustained protection. So in summary, there is an impact of VOC on VE, especially after a single dose. The VE varies by VOC, it's not uniform. B117 does not reduce VE much. B1351, so the South African variant, reduces VE, especially for the AstraZeneca product, but also there was some reduction even for the Pfizer product. For the Indian variant, the B1617, we can see also a reduction in VE after a single dose for all vaccines, but not too much after 2 doses for the mRNA vaccines. Finally, P1 also reduces VE, but as you had seen in these slides, the reduction is after 2 doses is not too bad, and in that sense, I think that we have a good demonstration that for the current time, the VOCs are not making a big dent in the protection that we will get after 2 doses. However, if we want to avoid the need for repeat booster doses due to variants, we should invest in vaccine options that don't target the obvious mutable spike protein, and we will need to increase the breadth and depth of immune response in our future vaccines, and probably looking at more than just this protein. So thank you.
Thank you, Dr. Dassin, for this very informative overview of vaccine efficiency. Indeed, there will be a lot of questions regarding this. Our next speaker is Dr. Soren Gantt. So Dr. Gantt is a pediatric infectious disease specialist and the director of the clinical research at the CHU Saint-Justin in Montreal, full professor in the Department of Microbiology, Infectious Disease and Immunology, and of Pediatrics at the University of Montreal. So Dr. Gantt's research interests include the study of determinants of viral transmission and prevention of disease. He has been involved in several clinical trials, and today he will discuss the opportunities and unknowns of COVID-19 pediatric vaccination, which is currently a hot topic. So welcome, Soren.
Thanks a lot, Louis. And thank you everyone for the opportunity to, can you see my slides here? Did that work? To talk about vaccination of children against COVID-19. I need to disclose that I receive consulting fees and research support from a number of companies listed here. So The reasons to potentially vaccinate children against COVID-19 include preventing pediatric disease directly, as well as the possibility of preventing transmission from children to other groups, particularly high-risk individuals, as well as to potentially allow more freedoms for children while the pandemic is ongoing. I'll talk about the current status of COVID-19 vaccines in children, as well as future studies, and I'll mention some issues around acceptability and ethics. So I think everyone probably realizes that that children have been much less affected directly in terms of disease by COVID-19 than adults. The vast majority of infections in children are asymptomatic or mild, and children represent less than 2% of all hospitalizations and less than 0.1% of deaths. However, you know, I just looked at this today, and there have been 11 deaths listed in Canada in children that were attributed to COVID-19, and this is on the order of what we've seen in the past with influenza, for example. So it's not trivial, of course. No pediatric death is trivial. And multi-system inflammatory syndrome in children, MIS-C, is a rare but serious complication of SARS-CoV-2 infection as well in children. And there's a disproportionate burden of disease among minority groups of children. In contrast, there are enormous indirect effects on children as a result of the pandemic, particularly related to mental health, education, et cetera. And with respect to transmission by children to others, I would say at this time, it's still not clear what the public health importance of that is. We know that children can transmit SARS-CoV-2, and studies have demonstrated that they tend to shed virus similarly to adults, similar viral loads, for example. However, a number of different types of studies indicate that in particular young children may be infected less often, whether that's biological and or behavioral related to exposures is not entirely clear. And there's been relatively little transmission in schools, albeit with prevention measures in place. However, this could increase in the setting of more transmissible variants. So I think it's reasonable to expect that there'll be more pediatric infections. In general, the reason we vaccinate anyone is to prevent disease, particularly severe disease, even if infection still occurs. And a vaccine that prevents disease but not infection may or may not affect onward transmission. There's a couple examples of that here. So for example, inactivated poliovirus vaccine prevents disease, but it doesn't prevent infection really, or shedding in the stool and transmission. Rotavirus vaccine, in contrast, prevents severe disease, as well as reducing shedding and transmission. And that is in contrast to a vaccine that prevents infection altogether, which is achieved by sterilizing immunity. It's I think, probably not realistic for COVID-19 to have a 100% sterilizing immunity with any vaccine. But in a case where an infection is averted, that de facto prevents transmission, because you have to be infected to infect someone else. And this is achievable. For example, measles vaccine is an example of that. And this is just shown schematically here, where the diagram on the left depicts a vaccine that does not reduce the number of infections, but reduces the severity of the infections that occur, as opposed to on the right, this type of vaccine reduces both the number of infections as well as the severity of any breakthrough infections that occur. So in Canada, currently, we have 4 licensed vaccines. The PFIZER vaccine is licensed for 12 years and older. Moderna, AstraZeneca, and Janssen vaccines are approved for 18 years and older. And Gaston mentioned this as well already, but all of these vaccines have shown to be extremely effective in clinical trials in the prevention of symptomatic COVID-19. So that was the primary outcome measure in those phase 3 licensure trials, as opposed to asymptomatic infection, which occurs frequently, and as I mentioned, is the most common occurrence in children. We know less about prevention of asymptomatic infection by these vaccines. However, the evidence that's accumulating suggests that asymptomatic infection is reduced with Moderna. They tested asymptomatic participants before the second dose, so after 1 dose, and positive PCRs in the vaccinated group, 15 versus 39 in the placebo group. So these are small numbers, obviously. Either participants who were either asymptomatic or they looked at asymptomatic seroconversion and found a 74% decrease there. Subsequently, there have been numerous effectiveness studies that indicate a decrease in asymptomatic infection, and I've just taken a screenshot from the US CDC site here that summarizes several of these, 2 from the United States and 3 from Israel, among different populations, showing fairly high reductions in asymptomatic infection with the Pfizer, Moderna, and AstraZeneca vaccines. So I would say that this is all highly suggestive that we're going to see fewer infections total, as well as fewer symptomatic infections. However, translating some of these data into direct evidence of a reduction in transmission is more difficult. Those studies are harder to perform, but there are several that are ongoing where close contacts of vaccinees and controls are followed to determine the likelihood of secondary infection. And hopefully we'll have more data soon in that respect. In the meantime, we have a fair amount of data on the viral load of infections, of breakthrough infections among vaccinated individuals. And viral load is a fairly good proxy, I would say, for infectiousness, and it correlates with likelihood of transmission. For the AstraZeneca and Pfizer vaccines, there did appear to be an impact on decreased shedding among those individuals with breakthrough infection in the United Kingdom. And I'll show you in a moment some data from Israel that demonstrated a reduction by 2.8 to 4.5 fold in the viral load among people vaccinated with 1 dose of Moderna vaccine when they were tested, when their infection was detected greater than 12 days after their vaccination, as opposed to earlier, and that was among 5,000 individuals. Those data are shown here. where the PCR cycle number, which is a proxy for viral load, the lower the cycle number, the more virus is there. And you can see that during the first 11 days here, the cycle number is lower first 11 days after vaccination than 12 days or later when people became infected in Israel. So again, suggestive of an impact on transmissibility. The data that we have in adolescents is currently primarily from the PFIZER trial that was just recently published in the New England Journal, where 12 to 15-year-olds were randomized to the same dose of mRNA vaccine that adults get, or placebo. And the primary endpoint in this trial was non-inferiority of neutralizing antibody titer. So it was an immunobridging study. And indeed, they met their primary endpoint of non-inferiority, and the neutralizing antibody titers were actually higher among these adolescents than the 16 to 25-year-old group vaccinated similarly. And furthermore, they reported that there were no COVID-19 cases among vaccinated adolescents compared with 16 in the placebo group. Thus 100% effectiveness or efficacy. And the reactogenicity was similar to the 16 to 25-year-old group, and the vaccine was safe. There were no serious adverse events attributable to the vaccine. It should be noted that reactogenicity of the Pfizer vaccine is higher in younger individuals than in older adults, roughly twice as high compared to the greater than 55-year-old group, but indeed it is safe. And then Moderna, these are unpublished data from Moderna, but in their press release, they reported in a trial of 12 to 17-year-olds that they also met their primary endpoint for non-inferiority of antibody responses, and 0 cases among vaccinated individuals compared with 4 cases in the placebo group, with comparable reactogenicity to the older group. So we'll await regulatory review and publication of these data. If you look on clinicaltrials.gov for pediatric COVID vaccine trials, there are many. Most of them are being conducted in China. I don't have a lot of information on them. I do know that Pfizer and Moderna are conducting trials currently in an age and dose de-escalation fashion down to 6 months of age. And the results of those trials are anticipated this fall. Novavax and Janssen are also testing their vaccines in the 12 to 17-year-old group. And the AstraZeneca product is, I believe, still on hold in children due to concerns about vaccine-induced thrombotic thrombocytopenia. So just briefly, in terms of acceptability and ethics, anecdotally, it seems like the uptake of the Pfizer vaccine is pretty good among adolescents, both in Canada and the US so far, from what I can tell. Although I think it's likely that hesitancy is going to be an important issue in a large proportion of these kids and families. Again, it's a fairly reactogenic vaccine, which may cause some concerns. And there can be issues around parental consent. So this varies by region. In Quebec, for example, parental consent is required for kids less than 14. And children 14 to 17 can refuse the vaccine, irrespective of their parents' wishes. This is different, for example, from Alberta, where, as I understand it, parental consent is required for everybody less than 18. And I'll just mention that there's a little bit of a controversy about the relative value of vaccinating children in resource-rich areas versus donating that vaccine to low and middle income countries where there's severe shortages of vaccines for high-risk individuals. And the WHO just recently made a statement to that effect that we should consider delaying vaccinating kids and donating to COVAX. And this is just showing the percentage of vaccinated individuals by continent here. You can see obviously Asia and Africa remain much lower than North America. So in summary, currently we've got the PFIZER vaccine approved for 12 to 18-year-olds. I anticipate Moderna will be approved soon, barring any unforeseen problems for kids greater than 12. We should have data down to 6 months olds for the mRNA products by the fall. And the reasons to do this include direct prevention of complications in kids, perhaps a reduction of transmission from kids to high-risk groups, although I would argue we don't really have high confidence that will make a big public health impact in that way. However, I think it's very likely that high rates of vaccinations among kids will help to ease restrictions around normalizing behaviors in school, sports, et cetera, and make quality of life better for them. There's this controversy about prioritizing kids here over high-risk adults elsewhere. And obviously, as these vaccines are rolled out, surveilling for unforeseen adverse events is going to be extremely important. These vaccines need to be extremely safe given the low rates of disease in children. So that's it. Thank you very much.
Thank you very much, Soren. Our next speaker is Dr. Mélanie Dieudé. Dr. Dieudé is an immunologist and professor associate at the Faculty of Medicine at the University of Montreal, also researcher at the Centre de Recherche du Centre Hospitalier de l'Université de Montréal, the CRCHUM, and she's the executive director of the Canadian Donation and Transplantation Research Program. And today, Dr. Dieudé will talk about prospective evaluation of COVID-19 vaccine in transplant recipients, a national strategy. Mélanie?
Thank you so much, Louis. Do you see my screen, my presentation? Excellent. So first, I'd like to thank the organizers for the invitation, and I'm going to try to provide some answers, but I'm afraid I'm going to have more questions than answers, but I'm going to try to tell you how we organize ourselves in Canada to participate to the knowledge, to get some knowledge around the vaccine, COVID-19 vaccine and transplant recipients. So I would like first to acknowledge and thank the diverse Indigenous people whose footsteps are marked for centuries the territory on which University of Alberta, host of CDTRP, is situated, such as the Cree, Saulteaux, Niitsitapi, Métis, and Nakota Sioux. And I would like also to acknowledge that the land from which I'm presenting today is the traditional and unceded territory of Kanenyaga, a place which has long served as a site of meeting and exchange amongst nations. So to give you a little bit of background, there's approximately 40,000 people living with a solid organ transplant or allogeneic stem cell transplant in Canada. And transplant recipients are increased risk of severe COVID disease to the concurring comorbidity and lifelong pharmacologic immunosuppression. Canadian data on SOT recipients infected with SARS-CoV-2 show approximate 55% hospitalization rate and 12% mortality. And this is a Canadian study led by Dipali and Kurmar and on nationwide. Similarly, population-based data worldwide confirm a 2 to 5-fold increase in mortality in infected transplant recipients compared to the general population. We know that exogenous immunosuppression may lead to prolonged viral shedding, increased infectivity, and a lower barrier to variant emergence, as they've been observed with other viral infection in this population. And similarly, recipients of allogenic stem cell transplant have dire outcome following SARS-CoV-2 infection, with only 68% of patients alive 30 days after diagnosis. However, there's currently very limited data on safety and vaccine immunogenicity and efficacy in this population. Based on experience with previous vaccine, mRNA or vector-based replication deficient vaccine is generally believed to be safe in transplant recipient, although such vaccine have not been specifically studied. It's only starting. Beyond safety, however, vaccine studies such as influenza and transplant recipient have consistently demonstrated lower immunogenicity and likely lower efficacy compared to non-transplant patients. And vaccination may also carry a theoretical risk of causing alloimmune and autoimmune responses, leading to graft rejection or graft-versus-host disease in stem cell recipients. So I will give you some data. So there's several studies coming up very slowly in the world of transplant recipient, and I'm going to focus on this study from, and they have several publications from the group in John Hopkins. And they started with 187 solid organ transplant recipients who received their first SARS-CoV-2 vaccination dose. They had different type of solid organs. So we often stratify with kidney, liver, heart, lung, kidney, pancreas, and multi-organ recipients. And they had approximately 50-50 Pfizer and Moderna, so all mRNA. And what they saw in terms of reactogenicity is that they had typically mild, minimal peri-vaccine reactogenicity after the first dose, similar to reported rates on solid organ transplant recipients, and no reported episodes of acute rejection and neurological diagnosis or major allergic reaction, which was quite reassuring. This was published in February. Following that, there was a publication early May that showed some data after a single dose of SARS-CoV-2. So they increased their cohort with 436 transplant recipients. And what they saw is that the majority of the participants did not appreciate anti-spike antibody responses. However, a younger participant not receiving anti-metabolite maintenance immunosuppression and vaccinated with Moderna were more likely to develop some antibody response, but still much lower than what we see in immune competent population. And this is just out, like in June 1st. They're now at 658 participants. 54% of these patients had detectable antibody response after the second dose, so it's much better. Although participants without a response after dose 1 had generally low antibody levels. Antibody levels were low compared to reported immunocompetent vaccine, so they were not at the same level at all. And there's a poor humoral response. This poor humoral response was persistently associated with use of anti-metabolite immunosuppression. So this data suggests that a substantial proportion of transplant recipients likely remain at risk for COVID-19 after 2 doses of mRNA vaccine. But I have to say that there's some limitation from this study, even acknowledged by the authors. So there's a lack of an immunocompetent control group within the study, and there's a lack of exploration of memory B cell or T cell responses and other type of immune-mediated responses. So in summary, the scarcity of the knowledge on the immunogenicity, safety, and efficacy of COVID-19 vaccine in immunosuppressed transplant recipients limits development of appropriate preventive public health measures. So this was an opportunity, and the opportunity was to use our Canadian network of stakeholders to develop a coordinated knowledge generation strategy to address the outstanding gaps in transplant COVID-19 immunization. And we banked on the CDTRP, the Canadian Donation and Transplant Research Program, with the mission of One Transplant for Life. And in a nutshell, we're a network uniting solid organ, hematopoietic stem cell donation, and critical care, and as well as tissue, actually, and cornea recently, around patient, donor, and family priorities. And we're grouping under a coalition agreement in 37 centers and universities across Canada. And so CDTRP offers research support and infrastructure to the organ donation and transplant community to accelerate research and innovation by fostering multidisciplinary collaboration across all research sectors and linking partner organization and international collaborators. And of course, integrating patient, family, and donor throughout the organization. So the first thing we did early January is to bring together an expert panel, and you can see the report at cdtrp.ca to really identify the knowledge gap around vaccination and transplant recipient. And then we had end of January as a big stakeholder workshop with many 41 partners, really to build that consensus knowledge generation roadmap. And that led to the study that I'm going to present here, which has the overarching goal to determine the immunogenicity and safety of COVID-19 vaccine in transplant recipient, both solid organ and allogenic hematopoietic stem cell, using a national multi-center approach and leveraging established networks. So the objective of the study is to prospectively assess the immunogenicity and detailed safety profile of COVID-19 vaccine in transplant recipient, to develop a national safety surveillance system of COVID-19 vaccination amongst transplant recipients, to coordinate the effort of a national and provincial organization involved in public health and vaccination research to share current and emerging data, and to build a lasting knowledge transfer platform to rapidly disseminate the research results to patient partner and public health agencies. So this is the team. You can see there's people all across the country. The team is led by Dipali Kumar in UHN, and there's several co-PIs and co-Is, and this is really an amazing group merging adult, pediatric, SOT, and stem cell transplanters, transplant ID, and immunologists. We have multiple partners to this team, so patient partner and patient groups, very important. And I know that there's some people here on the call here. I'll say hello later. Cell Transplant and Cell Therapy Canada, Canadian Blood Services, the CST, Canadian Immunization Research Network, Canvas, Public Health Partner, HEMA Quebec, and many others. We're on 7 adult sites, 3 pediatric sites, and 3 stem cell sites. So our first aim is really to look at the immunogenicity and safety of COVID-19 vaccination and transplant patient. And the goal is to prospectively assess the immunogenicity and detailed safety profile of COVID-19 vaccine and transplant recipient. And we will assess humoral and T-cell response to COVID-19 vaccination coupled with surrogate and neutralization and patient-reported outcome analysis for safety markers. So this is a prospective observational cohort study with multiple transplant centers across Canada, like I showed you. We plan to recruit 600 transplant recipients who will receive COVID-19 vaccination. We want to have some kidney, lung, liver, heart recipient, and also stem cell and pediatric recipient. We have also recruited 200 immunocompetent control, and these patients are recruited via site PI from high volume transplant center, followed by closely and contacted by mass email, telephone, social media, and so on. The cohort are likely, because we're still recruiting, to receive Pfizer or Moderna vaccine, and a minority received or will receive adenoviral vector vaccine. And the interval between the vaccine dose will vary between 3 weeks to 4 months and will be accounted in the analysis. We're going to do the clinical assessment through questionnaire, clinical evaluation, and chart review. And we're going to get data on graft function, acute rejection, and other adverse event. And of course, we're collecting blood and cell at 5 time point, ideally pre-vaccination, 3 weeks post first dose, 3 weeks after the second dose, and 6 months and a year after the first dose. The primary outcome is the anti-SARS-CoV-2 RBD IgG, but IgM and IgA will also be measured. We're going to have surrogate and neutralization assays. We're going to look also for B memory response and cell-mediated immunity. And for secondary outcome, we're going to look for safety events related to the vaccine, local and systemic side effects, measure of graft function, development of acute rejection or acute GVHD episodes, the development of new or increased donor-specific antibodies, HLA antibodies that are, and the development of or new or increased non-HLA autoantibodies, and then a clinical diagnosis for COVID-19 and its severity, of course, and the comparison of vaccine immunogenicity in transplant recipient to natural SARS-CoV-2 infection. And our second aim is a population-based national safety monitoring COVID-19 vaccination among transplant recipients. And it's a broad population-based approach to that will allow us to capture safety data in a much larger number of vaccinated patients across Canada by leveraging Canvas COVID study. And basically, transplant recipients were encouraged to enroll in the Canvas study. And the team is connected with enrolled transplant recipient through Canvas. And data entered into Canvas will be transmitted to the study team, who will confirm the diagnosis of medically attended adverse event via medical record review. The outcome that we're going to look for is patient-reported severe adverse event, including local and systemic reactogenicity, and patient-reported rejection and GVHD flares up to 6 months after the last dose of vaccine. In terms of data analysis for this aim, we're going to look at the incidence rates of severe local and systemic event between transplant and non-transplant patient enrolled in Canvas, and between vaccinated transplant and unvaccinated transplant controls. And the incidence and severity will be reported by age, gender, time for transplant, transplant time, vaccine type, and prior history of infection. Very importantly, we have included in this study a knowledge translation and dissemination strategy that will first provide almost real-time answers to provincial and national public health policymakers, reporting through the method and timing that each have specified, including email, report, joint, and individual call. We hope that it will facilitate public health decisions to be made in real time. For example, do these patients need a third dose of the vaccine? And CTRP will create a French and English translation fast facts for policymaker as interim safety and immunogenicity data become available. We're also connecting with transplant professional and transplant centers, and this is with the support of different partners, and notably Canadian Blood Services, DODTC, and the Canadian Society of Transplantation and CCTC. And we will coordinate to send compiled results to the centers in real time, so they are also aware of the result of this study. And the result will be presented, of course, in different conferences. Importantly, very importantly, we're going to also communicate with patient family. We're going to have workshops to determine communication recommendation for consent method and timing, and disseminate through the patient partner network. In terms of timeline, so we're in the enrollment period. We have already 233 adults enrolled and 200 controlled. So we have and then we're starting very soon to analyze our data, and I hope you're going to follow the study throughout the year, and we'll make sure to disseminate as much as soon as possible. The unique contribution of the study, because there's international study and we don't want to be redundant, but in Canada, we're focusing on the granular characterization of SARS-CoV-2 specific immune responses in transplant recipient, neutralizing antibody-dependent cellular cytotoxicity, B memory, and T-cell immune response. We will be able to assess the impact of delayed interval between the first and second dose in some cases. We will be able to compare also natural infection response to vaccine response using another cohort, and assessment of long-term immunity to 1 year. So This is the acknowledgement. I could spend an hour just for the acknowledgement. This is a big team. So the PIs, Lori West, I see here, the lead with CDTRP, of course, the PALI and the whole team, our different partners, and at sites, all team members on the site have been working so hard, all the coordinators, the nurses, to recruit really fast those patients, the CDTRP management team and patient partners. Just a side note, patient partners, we've been studying, working together on another study on impact of COVID-19 pandemic confinement on mental health and behavior, and the group that we're meeting every week. We would have been today at 4 o'clock, our 52nd meeting, because we're meeting weekly, and I see a lot of people are here, so I want to say hi to them. And of course, thank you to the funders for the study, and thank you for the invitation.
Thank you very much, Mélanie, for this overview of this very large study, an important study. We're hanging with the looking for answers, but like as you said, you raised more questions initially, but the outcome once the study is finished, these will be very informative. So so thank you. Our next presenter is Jaris Swidrovich. Dr. Swidrovich is a member of the Yellow Quill First Nation and was born, raised, and continues to reside in Saskatoon, Saskatchewan. So he graduated from the University of Saskatchewan with the Bachelor in Science in Pharmacy, and then did a full-time doctorate in pharmacy at University of Toronto in 2013. So Dr. Swidrovich is dedicated to educating healthcare workers and students on Indigenous issues and reconciliation. And today we'll be talking about COVID-19 immunizations and Indigenous people in Canada. So welcome, Jaris.
Thank you so much. And thank you to everyone who is participating here today and for the invitation to speak. I will just share my slides here. All right, so as was mentioned, my name is Jaris, pronounced just like Paris, but with the J, and my last name comes from my Ukrainian father. So I've certainly had many benefits of being a white presenting status First Nations person throughout my life. I am a pharmacist and assistant professor of pharmacy at the College of Pharmacy and Nutrition at the University of Saskatchewan. I love engaging with people in less formal ways that are on social media. So I've provided both my Instagram information and also Twitter. I should also mention my pronouns are he, him, and I wish everyone a happy Pride Month and National Indigenous History Month too. So I was asked to speak about some of the challenges of vaccinating Indigenous communities against COVID-19, which is precisely what I am going to share with you today. In order to best understand these challenges, we must focus in on the historical and the current practices within the health systems in Canada. Certainly both independently have their own implications on vaccinating Indigenous folks across Canada against COVID-19, but together we need to consider them as a whole. I would like to, as I often do, acknowledge my ancestors in this talk, because I know that I draw upon everything that they have done in their lifetime when I present in these ways. So who you see here is my grandmother, Marina Elder, who survived the residential school system, and then also Peter Gilbert, my great-grandfather from Yellow Quill First Nation also, and he was the traditional Soto medicine man. So I have been working as an immunizer, even though I am a pharmacist, at the Saskatoon Tribal Council Indigenous Immunization Center. And so this has taken place at the SaskTel Center, it's called, which is the arena in Saskatoon, where I currently am here in Treaty 6 territory in the homeland of the Métis. So Saskatoon Tribal Council is the council of the 7 First Nations communities within a 200-kilometer radius of Saskatoon, one of those being my own own community of Yellow Quill First Nation. I've listed the website here because there's just some excellent videos on there already about what we've been doing at this Indigenous immunization clinic, which is actually open to everybody. It's Indigenous and non-Indigenous. And the first video you see on the top of this screen, I'm not going to play these videos today, that's just a screenshot. That is our chief, tribal chief, Mark Arcand. In his welcome video, it's under 2 minutes long. It is just such a beautiful, warm welcome to everyone in the community near and far to join in on becoming vaccinated at this clinic. On the bottom, you see Dallin Bear, who's a former counselor of Whitecap Dakota First Nation, which is very close to Saskatoon, just a 20-minute drive south. He is the project manager of this Indigenous immunization clinic. And what he and the rest of the team have accomplished is just so fantastic. I have only wonderful things to say myself. And to be quite honest, I have not heard any even constructive criticism from any member of the public who has attended this immunization clinic. Right from the get-go, when you come into the center, you're offered the opportunity to smudge with an elder who is present there every day. Then you proceed your way through the whole clinic experience, and when you leave, you are offered a gift box of cleaning supplies, a box of 50 masks, soaps, dish soaps, hand sanitizers that are all made and produced by a locally owned, Indigenous owned business. So just an absolutely wonderful experience there, and I encourage folks to check out both of those videos on the Tribal Council website, which I've just listed on the bottom, or certainly you can Google Saskatoon Tribal Council, and it's right on their home landing page. There's been a lot of attention in confidence or vaccine hesitancy, and the terminology that I have also used and some of my colleagues use is vaccine decision making, just to put a more positive spin, I guess, on the vaccination considerations versus going right toward hesitancy. I think that there's been a generally false, certainly there's people all over the world who have mistrust in the healthcare system, but there's been a generally false understanding or false understanding that Indigenous peoples, by and large, across the country of Canada, have a strong mistrust in the healthcare system, and that certainly is not always true. It still comes down to individual differences, but there are very much nationwide considerations directly directed at Indigenous peoples that would give very good reason to be hesitant or to perhaps take more time to consider the vaccination process. Folks might have seen this, this publication. I collaborated with Dr. Ian Mosby. He's a historian at what we're currently calling X University instead of Ryerson University, keeping in mind the very racist and discriminatory history of Mr. Ryerson, who that university is named after. So right now there's a protest being, so they're calling it X University. It was Dr. Mosby's research that elicited some of the experimentations done on kids in residential schools, including the vaccination experiments and also nutrition experiment. So he's a historian, and I, of course, am a pharmacist. So we worked together on this paper. It's open access, as everything is now on CMAJ, and I encourage folks to check that out because there's going to be a bit more information in that free paper than what I will share just over the next few minutes. We know that study after study has shown the vulnerability of First Nations, Métis, and Inuit communities to health crises like the one that we are currently facing still. This vulnerability very much is the product of a Canadian colonial policy regime that has guaranteed that Indigenous peoples have reduced access to adequate healthcare, healthy food, clean water, while also experiencing much greater levels of overcrowded housing, homelessness, incarceration, which we have now discovered are also independent risk factors for acquiring COVID-19. During Indigenous History Month right now, if you are on Instagram, I've been sharing this month, as I did last year, one post a day on Indigenous history. And the one that I shared yesterday had to do with Indian hospitals. And it was just really quite remarkable to browse through the history books and see how what was done back then has a lasting legacy still in the healthcare experience of First Nations, Métis, and Inuit peoples. There was a residential school that basically was converted into an Indian hospital at a reserve that literally bordered the city of Calgary at the time. And although that hospital existed right there, they weren't even able to access x-rays, for example, because they had no electricity, even though the neighboring city of Calgary enjoyed the benefits of electricity for decades. And only one practical nurse and one cook was the entire staff of that First Nations hospital. And so it's just quite incredible to see how no wonder many First Nations people feel a little bit weary when it comes to healthcare access, if that's how our families and ancestors have been treated throughout time. Each of these factors increase the possibility both of contracting COVID-19 and of having severe health complications as a result. And what I'm referring to is the factors that I just shared on the previous screen here, like clean water, overcrowded housing, homelessness, and incarceration, among many others. So really, it's quite imperative that Indigenous peoples receive priority access to vaccines for SARS COVID-19, so COVID-19 being the abbreviated version, of course. However, on the flip side, although I and many others understand the priority that's required for Indigenous peoples in Canada, there's also many folks who have explained that they feel like they're being experimented on. You know, we're sitting here in 2021 with dozens of our communities still without access to safe drinking water, but then why is it all of a sudden that we're a priority for this brand new quote unquote experimental vaccine, as some of what we've heard. So you can see how that would lead to some confusion. Fears and experiences need to be taken very seriously by doctors and other healthcare professionals, and need to be differentiated from the anti-vax movements that we've certainly seen on social media in recent years. Absolutely any human, regardless of ethnicity, could be part of an anti-vax movement, but the generalized hesitancy or decision-making that we're seeing for COVID-19 vaccines in Indigenous peoples across Canada is not an anti-vax movement. It's a very well-informed, calculated, based on past and current experiences, decision that is made by individuals and communities. So the reality is that well-documented examples of Indigenous peoples being subjected to medical experimentation does exist. So some of this came right from my co-author, Dr. Ian Mosby. So there was a 12-year trial of the BCG vaccine for tuberculosis on Cree and Nakota infants in Saskatchewan during the 30s and 40s. And then also many folks will have heard about nutritional experimentation in several Manitoba Cree communities and in 6 residential schools between, that should be 1948 and 1952. Also keeping in mind historical and current incidences of racism. And we do see here and there some media coverage of racist experiences of Indigenous peoples in healthcare. But keep in mind, these are only the situations that reach the media. I can say that working at St. Paul's Hospital here in Saskatoon for the last number of years, we have never had a day of fewer than 40% of all inpatients ever since inception of that hospital being Indigenous. So quite often, almost always, it's at least half of all the patients in that hospital. And it is just so disheartening to see the frequency and levels of racism that take place. It isn't always interpersonal either. Sometimes it's just the system not being able to access the medicines and practices that belong to your own cultural connections, because you have to access such care in an institution that is Western based. So when we look at the cases of Brian Lloyd Sinclair, who died in a Winnipeg hospital after waiting for over a day in the emergency room to be treated, recent news stories about Joyce Echaquan, but she certainly was much more than a news story, a wonderful human being, even forced and coerced sterilization of Indigenous women and girls. It was only a couple of years ago now that here in Saskatoon, where I live and work, that our health authority put on a media announcement that they were guilty of this and that it was still happening. So it's not like there's just a perception that perhaps it's happening. We know it's happening. And I was very disheartened to see that even in places like BC and elsewhere, that even social workers were coercing young women, Indigenous women and girls down to the age 12 to have an IUD put in. We also know that dozens of Indigenous communities are still without water, so it becomes quite difficult to have conversations about the importance and necessity of a COVID-19 vaccination when they still don't have access to safe drinking water. So having a prioritized discussion would be very important. Location certainly has been another challenge in many respects. So folks living in non-urban settings, so I'm thinking of northern, rural, remote, and reserve settings. This has been a challenge in multiple ways, including the freezing and refrigeration temperatures required for transport. Recent changes in temperature and storage requirements, though, have certainly helped, but have not eliminated this challenge. And I think that, at least in the circles that I've been working in, some folks have been hesitant to change the practice that they've been doing for the last few months, even though we've received guidance that we can not have it in the freezer for as long as before. And also access to information and marketing. When I'm walking around or driving through the streets of Saskatoon, I'm seeing COVID-19 billboards, advertisements on buses, bus stops, just a lot of information everywhere. In northern, rural, remote, and reserve communities, that either doesn't exist or it's at a much lower scale. So even access to information and building up your own health literacy regarding COVID-19 and its vaccinations is limited in those communities. Most of the COVID-19 information presented by major groups and organizations is created and disseminated through mainstream methods that are catered to the dominant group, so the non-Indigenous group in Canada. We know that Indigenous peoples need to be at every table, every strategy session, and visible in COVID-19 media too. It's quite remarkable going through an exercise where you're presented with resources that include photos of people and none of them look like you. It just feels like this doesn't apply to me. So we need to be represented in all of these materials. And also when we're talking about the benefits of the COVID-19 vaccination, it should be more than things like, let's get back to going to play golf, going to concerts, that kind of thing. But, hugging your grandchildren and thinking about the next 7 generations. Most Indigenous folks across this country will be very familiar with the 7-generation teachings. So if we were able to see something like that and the benefits and risks information about the COVID-19 vaccination, it's immediately identifiable because we're familiar with that teaching. The entire COVID-19 vaccination experience for Indigenous peoples should be grounded in Indigenous worldview and practices. Smudging should be offered, I think anyway. It's worked very well. It's not mandatory, but offered at the clinic. Even some Indigenous immunization clinics have been smudging the vaccines every morning or every time a vaccine is taken out of the freezer, just right over the vaccines themselves. And I just think that's so wonderful. And all staff should smudge prior to the opening of the vaccination center each day too. Partnerships between provincial, federal, and Indigenous health departments is ideal. Having the opportunity for non-Indigenous people to be vaccinated at the same place, like we have been at the Saskatoon Tribal Council Center, and in the same way, is a positive step forward in reconciliation too. However, this must also not compromise the ability for Indigenous peoples to have a culturally safe vaccination experience. Indigenous peoples and communities have been leading the way in the COVID-19 pandemic thus far. Indigenous communities are assisting others, even across our colonial borders. You might have heard of some communities south of the border in the United States, helping out just the general population of Alberta in distributing vaccinations. Many Indigenous specific resources have been created and disseminated, and that's really the last piece of information I'm going to share with you right now. There is so much wonderful information on this website. It's the National Collaborating Center for Indigenous Health. NCCIH.ca is the website, and you can see that one that just came out quite recently, Enhancing COVID-19 Vaccine Acceptance in Canada, is a really wonderful resource among so many many others there that you can share in your own ways. And that is everything I have to share too, and I look forward to the discussions.
Great, thank you, Jaris, for enlightening us on some of the difficulties and the reality of the Indigenous people. So that's very informative. So thank you. We're now in the Q&A part of the workshop. So I'll start with the first question. Maybe this is one for Soren and Gaston. Maybe if I'm not mistaken, the Quebec has recently approved, maybe Canada as well, approved the mix and match vaccine, suggesting that if you get an AstraZeneca vaccine first, you could go with the Pfizer or Moderna after. So there was one question in the chat saying that the mRNA adenovirus vaccines are used in humans for the first time. And then this person says, I believe that mixing these vaccines for the first and second dose is not a good idea because we don't know the long-term side effects. So what are your views on this?
Well, I think that for the long-term side effects of either using a non-mixed schedule, we have no idea either. These products are new, and we are learning slowly from the experience coming from all countries. Having said that, in terms of safety, obviously the reason why the mRNA vaccines are allowed for the second dose if you had received AstraZeneca as their first dose is not necessarily because we expect protection to be greater, but because of the reluctance of some individuals to get a second dose of the AstraZeneca product. Having said that, clearly the second dose of AstraZeneca product is not causing as much thrombosis and thrombocytopenia induced by vaccine as we see with the first dose. It's probably 10 times less frequent. And the reality is we have data about how short-term reactogenicity is with a mix and match schedule. And we see more adverse events, so systemic adverse events with a first dose of AstraZeneca followed by Pfizer compared to 2 doses of Pfizer or 2 doses of AstraZeneca products. But there are so few individuals that we have no clue about could there be nevertheless thrombosis with thrombocytopenia with the RNA vaccine following a dose of adenovirus vaccine. So I think that we are learning about the safety of these products along the use of these products. But the question here is if people are not allowed to get an mRNA vaccine for their second dose and they just get a first dose, yes, they could be protected, but not as well as if they had received 2 doses. And so it's really balancing the risks and benefits.
Thank you. Maybe to follow up on this, a question for Soren, the $1 million question. Why are kids so protected from disease from COVID-19, SARS-CoV-2 infection?
We don't know is the bottom line. I mean, I think there are a lot of speculations about differential immune responses. It's very clear that there are age-dependent immune responses to infection vaccines, and so are children mounting a less inflammatory response to SARS-CoV-2 infection. I think that's one possibility. There are these studies indicating that ACE2 expression may be lower in children, and I think it's plausible that plays a role in the differential pathogenesis in children compared to adults. Are there things that are just as simple as more healthy endovasculature and essentially fewer comorbidities that are essentially subclinical related to aging and the the process of basically what we have is a lot of hypotheses and some interesting preliminary data, but we don't really know.
That's what I thought. The another question: is there any evidence of long COVID symptoms in children? Because we see this in adults, but do we see this in children?
Yeah, it has definitely been reported. It appears to be rare, given that symptomatic infection is relatively uncommon, and severe disease is rare in children. The minority of kids that then have persistent symptoms makes that an even smaller population of individuals, but they do exist. And in addition, there are some kids who have persistent effects from this post-COVID multi-system inflammatory system syndrome, and so there are groups around the country and around the world studying that, and so there, for example, my colleagues Seyman Say and Fatima Kakar are studying that and have a clinic here at San Justine looking at that. They've, there's not very many patients, but of course, the kids who are suffering, it's important to understand what's going on and try to find some effective treatments.
Great, thank you. I have a question for perhaps Gaston, who's the epidemiologist. Did we see, let's say, somebody that did natural infection with COVID, with SARS-CoV-2, and one that get 1 dose or 2 dose? What's the infection rate compared? What's the immunity like between the vaccinated people and the naturally immune people in terms of susceptibility to reinfection?
Well, I guess the susceptibility to reinfection or to infection, if you are naive versus the person who has been infected, well, there have been follow-up studies that initially said that over 3 months, we see a 80 to 90% reduction of risk compared to a naive individual. Then the follow-up was longer. It moved to 6 months and appeared to still be maintained at this level over a 6-month period. And we have seen studies where people receiving not about the effectiveness or the reduction of the infection, but looking at how they respond if they have been infected early in the pandemic and were given a first dose of vaccine, and they react as if they really had a strong immune booster response, so a recall response. So at the present time, we don't know how long an infection will protect an individual. So it's not a full protection. We had individuals who were reinfected even as early as within a month of the first infection. But the vast majority of those who had been infected will resist reinfection at a high level, hovering around 80 to 90%, as I said. And it may last for long, but again, I think the question here is more about how will variants affect that protection? And this is unknown at the present time.
Great, thank you. There's one question for Dr. Swidrovich. What are the research priorities pertaining to Indigenous people and COVID-19 vaccines?
Sorry, I just missed that one. Could you repeat it?
What are the research priorities pertaining to Indigenous people and COVID-19 vaccines?
Oh goodness, that's a very heavy and loaded question. I think that there's a whole bunch and probably different based on each community too. I know that sometimes there can be like a pan-indigeneity sense of who we are across Canada, but even within First Nations people, the Cree are very different than the Saulteaux, who are different from the Lakota, Nakota, etc. So there's just a lot of diversity within each community, and so that would be difficult. But probably having just community level driven research for their own stated priorities would be the best. I'm not a fan of things like, does this vaccine work better or worse in Indigenous peoples, for example, in the Canadian context, because then we start to assume that there's genetic differences between us, which is false. We need to look at the social circumstances between Indigenous peoples by and large versus everyone else in Canada. So when you're living in a way that you have such poor or no access to safe drinking water, overcrowded housing, poor or no access to health services, of course you're going to fare worse in various medical conditions versus people who don't have those challenges. So rather than providing one specific or even a few specific research priorities, I think that would just be up to each individual community.
Great, thank you. And maybe one last question for Mélanie. I think I saw in your some of the slides, you were focusing mainly on solid organ transplant in your studies. Is there a sub part for the stem cell transplant? And do you?
Yeah. We're also recruiting stem cell recipients. Yes, absolutely.
And do you expect these, if I'm not mistaken, these at one point are not so much immunosuppressor, do not take at one point immunosuppressant anymore. So you would expect these maybe to respond differently than those with solid organ that do take immunosuppressant forever, right?
Yeah, absolutely. And I think that's exactly what's going to be interesting. And even if you stratify between the organ groups, you're going to see very different immunosuppression according to the organ. So normally lung transplant recipient have a higher immunosuppressive regimen compared to liver, for example. So with that study, including stem cell was very important, and including pediatric was also very important, because as we know, and I think Soren really highlighted, they're not small human and they might react quite differently. So yeah.
Great, thank you. There's 3 minutes left, so I'll end the Q&A period, and I'll turn it over to Susan with the final words for this COVID workshop. So thank you all for participating, and then thank you the presenters and the attendees. So Susan?
Thank you. Thank you so much, everyone. This has just been an incredibly rich and diverse set of presentations that have been really enriching. And we'll send all of you the chat. And if you have time, you can feel free to provide some answers and entertain further exchange with people if you like. And particularly if you're our CanCOVID platform, if you're not already a member. So thanks everyone for participating. Delighted that we had such a wonderful turnout, and enjoy the evening. Thanks so much, Louis. Excellent work. Yeah.
Thank you, everyone. Bye-bye.
Bye-bye.
We would like to thank our speakers and members of our network for their continued support and participation in Canada's pandemic response. If you are interested in learning more about CanCOVID or joining our Pan-Canadian COVID-19 Research Network, please visit our website at www.cancovid.ca.